Hey, Matita.
Hi, Dr. Hoban.
Oh, how have you been? It sounds like Chicago may have gotten more snow and ice than we did yesterday. Did you make it through the weather okay?
Yes, I think this year is really cold, but it's kind of warmer than last year, but it's the kind when it's cold, it's really cold.
Yeah. Yeah.
And but I look at the temperatures in Ann Arbor, is that it's not that much difference from Chicago as much.
Yeah, not too much. We're usually not too far apart, but oh well. We it seemed like the winter was going to be a little bit warm and dry until the last couple of weeks, and then I think we just got a reminder of what winter weather can be like.
Yeah, I'm glad that I will fly there when it's kind of warmer, not like last year, not like last week.
Yeah. So some folks will probably be coming from another conference, so we may want to allow a couple minutes for people to filter in. But then when it looks like we have a quorum, I can introduce you and we can get going. Okay.
Okay, sure. Yeah, thank you, Dr. Hoban.
Yeah, hey, this is Shelley. Nice to see you.
Nice to see you, Dr.
Yeah,
Hersher.
yeah. I love your backdrop too.
Yeah, thank you very much. It's kind of like one of the University of Chicago library.
Like me floating above University of Michigan. Yay.
Yeah, that's true.
Well, very nice seeing you. I'm looking forward to this.
Thank you very much. And Dr. Hoban, do you see my screen okay on another side?
Yeah, the screen looks just fine.
Thank you very much. Hi, Dr. Hassan and Dr. Mountain.
Hey, Montita, good to see you.
Nice to see you again.
Hi, Manjita.
Hello, hi, Dr. Chachika. How are you?
Welcome. Good. Good to see you.
Good to see you as well.
Excited about your talk.
Yeah, thank you very much. Nice to see you.
And we can allow one more minute and then hopefully we're close to a quorum here.
Hi, Martina.
Hello, hi, Dr. Sherwin.
Welcome back.
Yeah, thank you very much.
Anita, do you think we can get going? Okay. Well, everybody, welcome to Sleep Medicine Grand Rounds. It's my great pleasure to introduce Mantita. Mantita had gone to medical school at Chulalongkorn University in Bangkok, Thailand, and then this is followed by training in pediatrics and child neurology, both in Thailand and at Children's Hospital of Michigan. Mantita then joined us as a sleep fellow here at Michigan Medicine before returning to Thailand, where she was a lecturer and assistant professor at King Chulalongkorn Memorial Hospital between 2013 and 2020. Mantita then came to the University of Chicago, where she has served as the pediatric program director for the sleep center there, as well as assistant professor. She has maintained a wide range of interests, including being active in many aspects of international pediatric sleep medicine. She has 26 publications, a book chapter, 21 abstracts, and as I said, a wide range of interests. So please join me in welcoming Mantita back to Michigan.
Thank you very much, Dr. Hoban and all faculty for welcoming me back to give a talk today. I'm really excited to be back, even by Zoom, and to give a talk. So today my talk will be about abnormal movements during sleep in children. So the outline for the talk for today, I like to do the approach to the abnormal movement during sleep in children, benign neonatal sleep myoclonus, hypnic jerk, and sleep-related rhythmic movement disorders, and REM sleep parasomnia, and restless leg syndrome, and also the new sleep disorder in children that call restless sleep disorder. So I like to go with a flow chart to approach to differential diagnosis of a sleep-related movement disorder first. This will be my first question to ask, what this happen for the movement disorders? And we know that the movement that we see in neurology clinic normally will be occur during wakefulness. So if it occur in or around sleep, we will oh, this will be our more expertise for the movement that occur during sleep. And then we'll divide it to be simple or complex. If it's complex, it could be RBD or disorders of arousals, a non-REM parasomnia or epilepsy. But this is simple. It will depend on which body part that is localized. Is this on the jaw and face? This could be bruxisms or faciomandibular myoclonus, or it could be primarily legs, or a childhood. For the childhood one, this is the one that I will be talking into details. This is the benign sleep myoclonus of infancy, and also rhythmic movement disorders. And miscellaneous, this will be excessive fragmentary myoclonus and sleep starts. So the first one I will talk is the benign sleep myoclonus of infancy. I also wrote one chapters in the pediatric sleep disorders, case-based practical guide, about this topic. So I did a review on that. I'd like to show the video. We can see in neonates, normally a very few days, maybe around 10 days, and then occur only during sleep. And we can see in the abduction and adduction, and it could be fragmentary as well. And I will talk in detail after the video. So this disease or a sleep myoclonus is reported for a very long time, since 1982, so around almost 40 years, and then by Coulter and Allens. And I think it's characterized by myoclonic jerk, the one that we see in a video, that very quick and rapid. And at first we think it occur exclusively during sleep, and the onset is at neonatal onset. And then it's abrupt, and then if you wake the baby up, it will be stopped. EEG is normally normal, and it have an excellent prognosis. Then the incidence is around 0.8 and 3 cases per 1,000 births. I think I saw it maybe like 2 to 3 that I got like I think 1 in Thailand and 2 got consulted. I think maybe it's more than that, but to get attention, it have to be excessive. And the condition is more in male, and male to female is around like 2 to 1 from the largest studies. And then it's also have a genetic factor as well. But because they have the one that we have to be in the differential that call like benign familial neonatal seizures that have the mutations in the KCNQ2 and KCNQT3. So I think that we try to, AlphaV and the group try to see, this is the autosomal dominance, this is allelic in the same potassium channel as the benign familial neonatal seizures, and it's it's not allelic with this potassium channel in the benign familial neonatal seizures. But the pathophysiology is not like fully understood yet, but they have like 2 hypotheses that reported for this BNSM. So the first one, the hypothesis, like at first we don't know where is this myoclonus coming from. Is it from like our brain cortex, or is it from brainstem, or like spinal cords? But from the research that combined the EEG and polymyography suggests that the generator is from the cervical spinal cord. And then they also have another study that postulated is immature or imbalance in the serotoninergic systems. And before we think it's only the arm that involvement, but in the report, it can happen in the head and in the facial as well. And the facial involvement is thought to be from the immature of the cortical bulbar tract. And the cortical bulbar tract is kind of like myelinated before the cortical spinal tract. And this is maybe explain why the BNSM like stop at around like as maybe the same time as the maturity of the myelination of the cortical spinal tract. So the presentation is very kind of like more in the neonates. The earliest one could be 5 hours of age, but the median onset is at around like 7.5 days. It's occur like upper and lower extremities. If it's like asymmetric, I think it will be kind of like easier to diagnose. But if it's like unilateral or have like focal or lateralized features, it's maybe like maybe more like difficult to diagnose. And they have some case that reported as a status epilepticus as well. So, and like in the video that I showed before, you can see it's irregular frequency. It's not like in the clonic or like more rhythm, it's more irregular. And it's have like 2 to 3 like rapid abduct and adductions. And normally they will have a short pause. Another one that in like pediatric neurology world that we have to be differential is the infantile spasms as well. That can have like abduction and adduction, but it's more have a tonic, a little bit follows the myoclonic jerks or like the pain associated with it and occur more during wakefulness. And then as I discussed before that head and facial can be rare, but it's found around like 11% from that past research. And then some manure that we think we can calm the baby down is kind of trigger the baby to be more aggravate this BNSM to be excessive. Like if we have like repetitive sounds or we do like tactile stimulus or rocking, will provoke this. And another one, that's why some cases turn to be status epilepticus, but not the true status epilepticus, but mimicker of status epilepticus because benzodiazepine was worsened and exacerbate the myoclonic jerks. And the first report of like the couple case report that was reported in the literature in 2007, sometime before that we know this entity very well, we give the patient with a phenobarb in the early one, so this can be exacerbate. Another one is have to be like wake up for the kid to be stopped. Even we try to restrain, it doesn't stop the myoclonic jerks. And then what is the differential diagnosis of this one? It could be from jitteriness in neonates. Another one that we can see the very like a tremorous in children is a neonatal drug withdrawal. or like it could be like physiologic hypnic myoclonus, and then or like neonatal seizures. I just see one maybe like last week about neonatal seizure, like a fifth day with like benign familial neonatal seizures. And then it will be more like unilateral more, and then it could be like a mimicker of neonatal status epilepticus. And then how to differentiate between, we try to see, is this the benign one, like BNSM, or this is their neonatal seizures? Let me put a pointer 1 moment. So for the onset, it will be, BNSM will be mostly common in the first 2 weeks of life, but the neonatal seizure will be depend on the course. And semiology is different. In neonatal seizures, could be like tonic, clonic, multifocal clonic, or myoclonic. And normally in neonatal seizures, often we'll have the facial involvement as well. So that's why we like talk about like head and facial involvements. And then the one that I always ask as well, and we also ask is kind of the eye was open or the eyes closed during the episode. So this one will be the BNSM, the eye will be closed. But neonatal seizures, mostly the eye open. And then which thing that can trigger the events, like, but neonatal seizure can just occur abruptly, nothing that can precipitate it. And sleep-wake, like BNSM, have to be occur exclusively during sleep. Even now, we know that it can occur during wake as well, but it's a transitional, just like sleep going to awake, but not like exclusively wake. And then the EEG will be different. If the one that very atypical, maybe we need the EEG to capture the events to see, like neonatal seizure, it will be abnormal. And then the course for BNSM is healthy, normal neurological infants, and the outcome is excellent. So for the management, as we cannot do the EEG for everyone, but maybe in here we can do EEG for everyone. But for the typical BNSM that like occur only during sleep, and then doesn't have any unilateral, doesn't involve head and face, maybe we can reassure and tell parents that it will grow out by its own. But if it's a typical BNSM, maybe we need the video EEG, or maybe we need the EMG to be like deltoid leads as well, or legs leads, or like polymyography. What is a typical features that we may need the EEG? It could be like a prolonged durations, or like head and face involvements, or consistent focal features, or it's a kind of like occur during wakefulness. So this is the for the BNSM. Do the audience have any questions? I would like to share your experience.
It's been helpful with increasing availability of EEGs in some centers, is that it's sometimes easier to answer the question quickly with video EEG monitoring, especially in the atypical cases. The family history is also an important distinction, especially with some of the familial neonatal convulsion syndromes.
Thank you very much, Dr. Hobans. I will move to the next one with the hypnic jerks. Because we see like a sleep start. Before I knew that hypnic jerk is kind of like falling asleep and then you have a jerk. And then I have a patient come to see me just to complain of the hypnic jerk that very, very excessive. And I just found that sometimes it's have accompanied by tachycardia and tachypnea as well. So she was kind of complain of myoclonic, but complain with the tachycardia and tachypnea. This is new for me. I never know that when we have hypnic jerk, we will have a tachycardia and tachypnea along with the reported sensation of shock or fallings. But these ones we already know that it's triggered by environmental factors like fatigue, stress, or sleep deprivations. And normally, like, it's rarely too frequent enough to cause insomnia. But one of the patients that I saw that it's caused her like insomnia. So we kind of on the workup for the sleep studies now. But I think hypnic jerk will be another one of their abnormal movements that can come to see in the sleep clinic as well. And then for the next one is a sleep-related rhythmic movement disorder in children. That I also wrote like a mini review with my fellow last year, and we see like 3 sleep-related rhythmic movement disorders in children, like 3 cases in a row in around like 1 month. So I think like, oh, maybe we can do like the review in the for this entity that it doesn't have many articles or literature in the literatures. So let me show the video. This is my patients in Thailand that kind of like mom come to let me go into that brought to me regarding of his rhythmic movement disorders. This is occur every time before he going to bed. And mom is also worried about any like a safety concern about his head injury or not. And he was very, very healthy. And then we also see some like rhythmic movement disorders during like polysomnogram for other children as well. So for after I review the SRRMD, it's normally like when we talk about like not the disease, when we talk about like rhythmic movements during sleep in children. So normally it's kind of often like asymptomatic, and we think it's a kind of benign conditions that kid like grew out by its own. But when it's classified as the SRRMD, as in the ICSD-3, it have to be movement had to be significantly disrupt sleep and cause the daytime functioning, and also has the maybe can cause like self-inflicted body injury. If you look in the literature, it's sometimes really scary too, that it can cause like alopecia, like large scale defects, like cataracts, like subdural hemorrhage. And then at first in the ICSD-1, it was classified as first as the sleep-wake transition disorders. Because it's normally happen during while we like falling asleep and try to falling asleep. And then after several research, it seemed to be it's not occur just the sleep-wake transition anymore. It's also occur in non-REM 1 and non-REM 2, and it's also occur during REM sleep as well. So the prevalence is kind of varying with age, but normally it's occur more during infancy. In the infant, it's around like 59 to 67%. But for me, I feel that the one that during the infant one maybe not meet the criteria for SRRMD, but maybe just a rhythmic movements. And then we know that it's decreased by 33% by 18 months, decreased to 33% at around 1.5 years old, and then dropped to 6% at 5 years of age. But now they have the like a literature that is also persist into adolescence and adulthood as well, especially in children in adult with neurodevelopmental disability, like autism spectrum disorders or developmental delays. So it will be within my like specialty children that I also take care of, with the children with autism that sometimes even turn to adult, like 20 years old, still having these rhythmic movement disorders. And then it's also more common in Down syndrome as well. And then it's also associated with poor sleep quality. So they have a semiology of rhythmic movement semiologies. It could be like a upper, let me pull the pointers. So this one is kind of upper body movements. It could be with or without head banking, or it could be like full body movement with or without head banking, or like body rocking with the body rocking forward, and body rocking with the body rocking backward, or it could be head, just the head rolling, or it could be like a body rolling. So the incidence of each semiology, the one that the most prevalence is the upper body movement with and without head banging, followed by the full body movement, and then followed by the body rolling, and then go to be body rocking, head rolling, and the backward is just only 2%. And 4% that have both the B and E, like full body movement and head rollings. For the diagnosis that in ICSD-3, I didn't go into ICSD-TR yet for the revised one. So it will be like a repetitive or like stereotype movements, and movement is like kind of like a sleep related. And the one that's very important is the behavior have to result in significant complaint and have a significant impairment with the daytime functionings, and it cannot be explained by any other movement disorders or epilepsy. So what is the differential diagnosis when we talk about like sleep-related rhythmic movement disorders? Another one in epilepsy and Tai T that should be talking about is the sleep-related hypermotor epilepsy, or SHE. It's kind of like a before we call autosomal dominant nocturnal frontal lobe epilepsy. Like we can see like hypermotor movements or like even like dystonic of the hands and like wandering around during sleep as well. And other is kind of like benign epilepsy with central temporal spines or benign occipital epilepsy. That is this epilepsy that most occurring in children as well. If it's occipital epilepsy, it would be more like vomitings and autonomics. But I think currently epilepsy term, they also have new terms like CLES and CLEX, so, but I still using old term to be more understandable, but now like they have a new category for it. And then parasomnia or other sleep-related movement disorder, like a hypnagogic foot tremor or like bruxism, and also like thumb sucking and maybe like stereotypies in autism children that sometimes occur during sleep, like I think like sometimes we capture children woke up in the middle of the night and have a stereotypies. And normally in SRRMD, they have a comorbidity. That sometimes treatment of the comorbidity will help with the SRRMD as well. So we have to looking for the comorbidities like a OSA or like restless leg syndrome or any night terrors or insomnia. So I think like a PSG will be helpful to diagnose the comorbidity of either SRRMD. And then, and as we already talked before that we also found SRRMD more in ADHD patients or like a neurodevelopmental disorders or even in psychiatric disease like a depression or anxiety disorder. And then for the diagnosis, is have changing category from the ICSD-1 to ICSD-3. And ICSD-3 already highlight that SRRMD can persist into adulthood. And then it should be supported by home video recording. So I think for this one, it will be better for the diagnosis with a home video recording. And because history alone sometimes insufficient to diagnose it, and sometimes we have to differentiate with the seizures or find the comorbidity as well. And currently they have a novel like automatic 3D to analyze the home video somnography, like the record of the 3-night home video. And instead of we have to use the time and manpower to review all 3 nights of the home video with the autonomic 3D to capture the sensor, motor sensor. We will like try to like decrease the time to review it. And the rhythmic movements normally is have the diagnosis of the characteristic will be in the PSG will be the minimum of 4 rhythmic movements with a frequency between 0.5 and 2 Hertz. And amplitude have to be 2 times of the background of the EMG activities. So this is the examples of the rhythmic movement disorders, the sequence that like with the body rocking, we see the whole and of the PSG leads that see the rhythmic movement 0.5 to 2 hertz, and it's very different, look like a delta activities and increase more than like 2 times of the EMG background. And then for the pathophysiology, like why this has happened, it is still unclear, but they still have like hypothesis of the pathophysiology. So they have like a full pathophysiology that's have been approached. So the first one, the hypothesis of normal developmental variance, that this is kind of like it's just a normal development. The rhythmic movement is kind of like stimulate the vestibular system. That is a positive effect in motor development in infant. Another one that this is the hypothesis that I use in the treatment as well, that I try to do the self-soothe training and gradual extinction in the patients, as it's kind of hypothesis to be like self-soothing learning behavior, that the patients try to soothe themselves to sleep to be by like doing the rhythmic movements. And then the rocking movement is thought to be mimic the maternal movement, heartbeat, and respiration during in the utero. And then, but the recent research showed that it's associated with the lower maternal sensitivities. The third one is the hypothesis of disorder of arousals. It seems to be from fragmentation and instability of non-REM sleep that have like more cyclic alternating patterns. I think if we have the patient that come with SRRMD, we should look into CAP as well. And it seems to be involved with the arousal pathway in the brainstem that involve the thalamocortical reticular system. And then I think the fourth one is the hypothesis of central pattern motor generations, that about the abnormalities of inhibitory control in their central motor pattern. So it's impaired GABA release. So that's why sometimes we use the GABA drugs in this patient with neurodevelopmental disability to help with the central pattern motor generations. And then they also genetic disposition for this SRRMD as well. They have a case report in monozygotic triplet and twins, but we still doesn't know the genetic location yet. And sometimes it show like multi-generation families. For the treatment, they have no like a randomized control trial, but they have literature on hypnosis. This is interesting too. They have one case report of hypnosis in there. And then benzodiazepine, melatonin, sleep restrictions, and also cognitive behavior therapies. They have the first report is the clonazepam that used in adult with Fragile X. And then after that, they have a case report in children. And then behavioral approach, we do like immediate feedback or reward system or like aversion therapies. And if we have comorbidity, we should treat the comorbidity as well. Like they have a report about like CPAP, adenotonsillectomy, when we have OSA triggers, the SRRMD. And then the very important thing for this entity of SRMD is the safety interventions, that we have to focus on safety and injury preventions with the bed padding, removing the bed from the wall, or using the bed rails, or confirming the stability of the patient's bed. Oh, okay. So this is another one, or should we go to the next one as well? The next one is the restless leg syndrome. When I graduated from a sleep fellowship, I feel like, oh, I came back to Bangkok, I will file like my knee sleep restless leg syndrome, as this is very common. This is like the most common pediatric neurology sensory motor conditions, and it's kind of like 2 to 4%. It's maybe more than OSA, or OSA is around like 1 to 2%. But I'm not sure when it came back, I saw like maybe a few patients and more like teenagers and adults. But when I came back to to the US, it seems to be increasing more and maybe more in the restless sleep disorders as well. So I think it's still like a very important sleep disorder in children. And it's very impacts sleep, mood, cognition, and quality of life in children as well. And they have like a new entity they call like restless sleep disorder. It's just like a recently identified in pediatric sleep disorders. And the thing is, for this one, even it's just like restless sleep, but the current diagnostic criteria require the polysomnography as well, that to have body movements more than 5 times per hour. And then, and it's more prevalent in children with ADHD and parasomnia. And I saw, and from my experience, it seems to be more prevalent in children with autism as well. And also support like iron deficiency, sleep instability, and increased sympathetic activations. So I bring up the consensus on the diagnostic criteria of restless sleep disorders, that the criteria A to H must be met. So the first one have to have complaint of a restless sleep. It could be by patient parents, or caregiver, or bed partner, or by the patients. Another one, the restless sleep movement is not just only legs. It can be large muscle group, any large muscle group of the whole body, all 4 limbs, arm, legs, or head. And then the movements occur during sleep or have to be when appears to be asleep. And one of the criteria is the video polysomnography shows a total movement index by the video analysis of 5 or more per hour of sleep. And then the restless sleep have to occur at least 3 times per week, and then being present for at least 3 months, and then can have to be disturbed or have a significant impairment during the day and cannot explain by any other sleep disorders. So the key point between restless leg syndrome and restless sleep disorder, I think for me, it looks like the same entity. It's just like for me to increase the diagnosis to be more in children that sometimes cannot explain with their own words. And we use another diagnostic criteria. So a restless leg syndrome is more like a clinical diagnosis, and restless sleep disorders like require polysomnogram for diagnosis. And RLS can present with symptoms of sleep onset or sleep maintenance insomnia, and ISD present with non-restorative sleep. And both conditions are currently treated with ion supplementations. And in my experience before, they have a diagnostic criteria. Sometimes because with children in autism who has many complaints of sleep disorders, and we already rule out OSA, sometimes with the restless sleep, I also check the CBC, iron, and ferritin. And if ferritin less than 50 and with the history of picky eater, I feel like to supplement on the iron is very helpful and decrease the children's restless sleep as well. So for the literature between 2018 to 2022, so it's very recently new, that show evidence that RSD was kind of have evidence of the lower percentage of A3 cap, and also shorter durations of the B phase of the cap cycle, so increase the non-REM stability, and also increase the sympathetic activations, especially during non-REM 3 and REM sleep compared to the control. So it seems to be have evidence that they like disturb sleep for real in the literatures. And I think the thing that maybe this paper in journal, in JCSM, Journal of Clinical Sleep Medicine in 2021, that put the clinical criteria to be in the have polysomnogram involved, because when we have RSD and ADHD, the complaint of restless sleep could be 81.1% of children with ADHD if we do by the CHIP complaint alone, but only 9.1% will meet the criteria for diagnosis of the restless sleep disorders. And then restless sleep is mostly secondary to other sleep disorders or psychiatric comorbidity or medical use. So that's why when coming to the consensus criteria, they need to have the polysomnogram to meet the diagnostic criteria as well. And then pathophysiology of RLS or RSD, I think is the same. I think it's both one with the low intracellular iron and also dysregulation of dopaminergic neurotransmission. And it also have a genetic with the autosomal dominant with a genome-wide association study in the BTBD9 or mice1. And then like in movement disorders since in 2007 that shows the central brain ion that decrease between like RLS and control, we can see that the irons in the central brain, especially in the substantia nigra and red nucleus, like it's kind of like absent in the ILS. So it's a kind of real disease. So sometimes when I was trained too, is the kind when we have like sensory or somatosensory, sometimes it's hard to diagnose and hard to quantify. And I think this is kind of like RLS is kind of like we can prove is the real both in the that decrease the brain iron and CSF13 also low as well. And even when I come back to practice, like sometimes I tell children try to draw and see like what the restless leg syndrome like, but I never got the picture one of the restless leg. Maybe I can got like maybe the script how they like tell, but this is more in the paper about like sometimes it's mean like in children look like a stretching, and sometimes look like some like ants in the legs. But the pictures that I got like from the patient when I like with the migraine patient, I have like children like draw like how the headache like, and without like with the complaint by the words, it's really minimal. But when I got the pictures, it's really nice that we can see that he saw like double vision too during the drawing. So I feel like drawing will be better for like headache or somatosensory symptoms for restless legs syndrome in children as well. And then next one that I also interested into like a sleep bruxism in children's. At first, I think that maybe sleep bruxism is from two causes. Like one is the stress, and two is the like obstructive sleep apnea. And I think like I also have a chance to talk to like dentists like in Thailand as well. And I think now dentist is also like forefront for diagnose for like sleep disorders. And bruxism could be the one of the complaints of the symptoms of obstructive sleep apnea. But also sleep bruxism in children can be occur from other things too, like genetics, or like our quality of life expected life stress as well, and mother anxiety or family conformations, and diet or alteration in sleep behavior and architectures. And definitely is that when we have the patient that grinding in the teeth a lot, we have to rule out the obstructive sleep apnea or sleep breathing disorders as well. And then for the REM sleep behavior disorders or REM-related parasomnia, that could cause the abnormal movement during sleep in children as well. And RBD is kind of rare in children, that we didn't see it as often. So I'm going to like talk a little bit about like REM-related parasomnia. I think like this one we see all the time about the pathophysiology of REM sleep behavior disorders with the lack of pontine-mediated medulla inhibition of spinal motor neurons. And then what is kind of like when we talk about like RBD in children, as it's really rare, how that it could be diagnosed and how where is it found? It's mostly in neurodevelopmental disabilities. So RBD can be in autism children or like a Smith-Magenis syndrome. It could be in Mobius syndrome as well. I have one patient with Mobius syndrome, but I never see RBD in there yet, but this is a report that has happened. Smith-Magenis syndrome, Is the one that they talk to about RBD often. Another one is could be like structural brainstem lesions, as we showed in the picture before. So any lesion in pontine glioma or Kyrie malformation type 1, it could cause RBD. Another one is the movement disorder with the Tourette syndrome or juvenile Parkinson disease. Another one that when I got like RBD in children, I always ask about like narcolepsy or cataplexy symptoms. And then I think the one that I just see earlier is the kind of medications induced with the SSRI, like fluoxetine or venlafaxine. So for the diagnosis, we have to do the clinical combine between video PSG and to show the REM sleep without atonia. And we have to rule out that it's not OSA, PLMD, seizures, or GER. So the management for the, if we have RBD in children, because it is very rare, so for me, so I apologize for the other sounds as well. That they cannot control it. The MRI should be obtained, and we have to rule out the autism and Smith-Magenis syndrome, and rule out the narcolepsy. This one with the Smith-Magenis syndrome. And another one that when we talk about the abnormal movement during sleep, they have a myoclonic twitchings like during REM sleep that sometimes like happen in the infants. That it could be from the research in rodent or sensory feedback or twitching of the limbs. It could be from the brain activation during early development. So it's the kind of normal movement during sleep. Because when I was in Thailand, they have like a patient coming to see me, just the very abnormal movement when mom's very meticulous and see look like children playing the piano during like sleep. And this can be like a sensory motor mapping. So let me show the video. So sometimes it looks like in rats, or even if you can find like a little bit like in children too. And the research from the researcher that I go to the conference, that they try to mapping this sensory mapping to see that they can identify the early developmental disorders from the sensory mapping of this normal movement at during the young age in toddler as well. So I would like to end my talk here, and then thank you very much for your attention.
Thanks, Martina. That was great. I have a question. It just seems like compared to the last 20 years, I'm hearing more and more about the RBD in children with narcolepsy. I'm just wondering what your experience has been. Has that been a very common thing? And for years before, we just didn't ask about it enough?
I think for my narcolepsy patients, I didn't see RBD yet too. Even I also talk about this when we talk about the RBD, but I never see the patient with narcolepsy with RBD at a young age before.
When I've seen it in the college students, it's just usually more subtle. Like patients will sometimes recall like seeing their arm above their head, or just like, kind of subtle, not sort of like the dramatic 70-year-old male. But I'm kind of closer questioning, I get it. Some.
Tita, thank you for a wonderful review. You know, this is interesting because on the neurology side of things, we think of movement disorders as conditions where sleep usually is associated with improvement of symptoms. And these are disorders where, you know, the symptoms are primarily or exclusively related to sleep or sleep-wake transitions and such. There's a wonderful overview of the history and the science that that goes into this. You also brought up one area of evolving understanding, restless sleep disorder, that I think clinicians have seen that there are children with restlessness during sleep who do not always meet criteria for restless leg syndrome and periodic limb movement disorder. And restless sleep disorders proposed a framework for diagnosis. At the same time, it's not yet an officially recognized sleep disorder in the International Classification of Sleep Disorders. Plus, there are potentially practical limitations about how do you score the restlessness on polysomnography? How is that implemented? Have you do you have any thoughts on how those issues should be approached?
Yeah, in our sleep lab, currently we didn't implement this yet. And we think about after I review this, because normally we do the PLM and then we use PLM more than 5 per hours. But this one is a video review and body movement and 5 per hours. So I think about maybe we will start to do it. But maybe we have to score, like instead of when we see more body movement in the video, maybe we score at the bruxism area, but to count that to be 5 per hour and or any big body movements. I think technical wise, it should not be difficult to score for the 5 per hours, and it could be implemented.
Hi, Montida. How are you?
Hi, Dr. Caprice. Thank you very much for attending.
I had a question. If you can go back to your slide 42, I think. There was a comment made, unless I understood it incorrectly. I think in the RSD group, you said the A3 subunit is lower in frequency. And A3 component of the CAP is typically more consistent with the arousals. Are we saying that these people are these in RSD, the sleep is more stable and they are having more movements in large body movements in their sleep? I'm just trying to understand that concept.
I think the concept is this increase the instability of the cap of the so we see like the B phase that should be like longer, it's kind of like more bit shorter in this patient with RSD compared to the one with RLS control.
I don't know if you can share that slide. I just want to understand it. You are able to bring that slide out. Maybe you read it wrong. I think it's slide 42 or 43, I think. I think you are dwelling into a great point that we need to have more analysis of the microstructures, and potentially that will allow us to have a better understanding of these sleep disorders more effectively than going away from it, which the adult world has done. So I think that's something that's a good concept to understand. That's okay if you're not able to find it, no worries. Thank you.
I already showed it. This it doesn't come. One moment. Yeah. Does it show in the system?
That's okay, Monty, don't worry. Thank you.
Any other questions from anyone at this point? I don't see anything in the chat. Okay. Okay, well, Martina, I would like to thank you again for wonderful grand rounds and very detailed overview. And we are looking forward to seeing you in person very shortly.
Great job, Mantita.
Thank you.
Thank you. Thank you very much, everyone, for inviting me. Glad that you'll see you in person and by Zoom soon. Happy to be back and see everyone.
Thank you for the comment.
All right. Bye-bye.
Bye-bye. Bye, Dr. Hoban.
Okay, bye, Martina.